For Red October is about a silent deadly submarine, a useful metaphor for the diagnosis of pulmonary embolus. PE is all about finding the clot. Examine the literature on pulmonary embolus and you will find that the seminal papers all deal with finding the clot. In this lecture, we will review CT for diagnosing pulmonary embolus. CT visualizes the clot and has rapidly emerged as an important clinical tool which will ultimately provide new insights into the natural history of this process. Pulmonary embolus is common and poorly diagnosed. How big is your hospital? 1% of those patients have pulmonary embolus. Even though the world's literature is voluminous, I would assert that we know very little about the natural history of this disorder. Nearly all landmark investigations deal with diagnosis. Treatment is known and effective. The difficulty has been diagnosis. This is a common list of predisposing conditions. Note that this encompasses a very large patient population. Remember, prevalence is estimated at 1%. Arising from the deep veins, complete occlusion is rare. Symptoms arise due to ventilation of non-perfused lung. Respiratory failure ensues when more than 50% of the capillary bed is occluded. Clinicians have great difficulty in deciding who to test for pulmonary embolus. In fact, many patients don't have signs or symptoms. When symptoms are present, patients are just as likely to have other diagnoses as have pulmonary embolus. The same is true for signs. Clinicians are very uncertain as to who does or does not have pulmonary embolus. Numerous lab tests have come and gone. The most recent candidate lacks the sensitivity to diagnose PE. Chest X-ray is also unreliable. In fact, 10% are normal. Classic chest X-ray signs are infrequent. In fact, the Fleischner sign of the enlarged pulmonary artery actually decreases the probability of PE. VQ scanning has been the traditional test for PE. The problem is not sensitivity, but specificity. Based on VQ scan patterns, patients are classified into 4 categories. Unfortunately, most patients fall into the low, indeterminate category in which too much uncertainty exists. In addition, the largest category has poor inter-observer agreement. The main problem with VQ scanning is that the test does not primarily visualize the clot, only the secondary effects of the clot. Historically, all tests that rely on secondary signs, such as hypotonic duodenography for pancreatic masses, have been abandoned as soon as a test modality became available that could depict the primary pathology. Nuclear medicine physicians have been unsuccessful in developing an infarct-avid agent. To paraphrase James Carvell, a deep venous clot fragments in the right ventricle, showering an average of 8 emboli to the lung. In older studies correlating angiograms with VQ scans were not 100% sensitive for individual emboli. The important point is that for an embolic episode, there are multiple chances to make a diagnosis. The one traditional test that does depict the clot is pulmonary angiography. Various reasons have been given for the poor utilization. In any case, this is a rarely performed test. Pulmonary angiography is not perfect, especially for small subsegmental emboli. Similar to VQ scans, reader agreement for subsegmental emboli is poor. Over the years, little has changed in physicians' practice patterns. Pulmonary angiography is a rarely utilized modality. CT pulmonary angiography is a new modality that primarily visualizes the clot. Technologic advances, either spiral CT or electron beam CT, allows rapid acquisition during the contrast bolus through the pulmonary arteries. A typical spiral technique utilizes thin collimation, scanning through the central pulmonary arteries. If the patients have difficulty holding breath, start at the diaphragm and proceed cranially. The topmost images are not as subject to respiratory motion artifact as are the basilar images. If the patient cannot hold breath, quiet breathing still results in diagnostic images in most patients. Multi-slice CT adds the capability to do thinner slices and larger coverage. Timing of the contrast bolus is not as critical. One can combine CT venography with angiography. In a multi-institutional study of 541 patients, DVT alone was found in 15%. CT, as compared to ultrasound, is as accurate as ultrasound in evaluating the deep venous system. However, over time, the rate of positive CT pulmonary angiograms has decreased as physicians have realized the inadequacy of their history and physical skills in detecting pulmonary embolus. As a result, the positive rate is now less than 5%. Because of the large gonadal dose with venography, I have chosen to discontinue the routine use of combined venography and pulmonary angiography. Note the good concordance with the number of emboli detected as compared to historical studies of the number of emboli per embolic episode. A large number of studies have now been published. Entry criteria varied from correlation with pulmonary angiography, clinical suspicion, indeterminate VQ scans, or those with normal deep venous ultrasound. Combining all results, sensitivity and specificity are both high. In contrast to VQ scans and pulmonary angiography, reader agreement is high for both negative and positive interpretations. Most patients have diagnostic scans. The failure rate is similar to pulmonary angiography. Of some concern is the report that the sensitivity of CT is poor for subsegmental emboli. One of the normal functions of the lung is to remove small emboli. The lung is ideally suited to this task. It has a large redundant capillary bed and dual blood supply. The reservoir capacity of the venous circulation has the disadvantage of slow flow. Tiny clots may form and are removed by the lung. Normal emboli are hard to document. In an older study of normal volunteers, 5% had subsegmental defects at VQ scanning. What are the consequences of a single subsegmental embolus? Assuming an anatomic distribution of blood flow, and assuming a conservative 2 subsegments per segment, each subsegment receives only 2% of the total pulmonary blood flow. Normal pulmonary reserve easily compensates for this loss. If missed, these clots may have little consequence. For example, certainly subsegmental emboli are missed at angiography. However, the outcome of patients with normal pulmonary angiography is good. Subsegmental emboli are not a common manifestation of an embolic episode. In the PALPED study, only 6% of the patients had isolated subsegmental emboli. Note that if subsegmental emboli are important, VQ scanning remains a poor testing modality. Remember, there is not a reliable test for subsegmental clots. Similar to pulmonary angiography, the outcome of patients with negative CT pulmonary angiography is good. In contradistinction to VQ scanning, CT adds other information. Up to 2/3 of patients have other diagnoses at CT which may be the cause of the patient's symptoms. In this example, the CT angiogram was normal. Focal consolidation in the right upper lobe, due to pneumonia, was the cause of the symptoms. When reviewing CT angiogram studies, it is important to review the scan on a workstation and cine back and forth between sections. This greatly facilitates the visualization of small clots. Various other window widths are also helpful. Here the bone window better demonstrates the calcification in a chronic embolus. Lung windows are valuable for small emboli. Here the clot is barely perceptible on the mediastinal windows, but seen to better advantage on the lung window. I find reconstructions less helpful. However, for oblique running arteries, particularly through the lingula or right middle lobe, reconstructions may be helpful. In this example, the subsegmental embolus is seen to better advantage in an oblique coronal plane. False positive clots are related to motion artifact, asymmetric filling, or normal lymph nodes. It is helpful to have a handy chart showing the normal locations of lymph nodes. Occasionally, an unexplained drop in the concentration of contrast in the artery is mistaken for a pulmonary embolus, as is seen here in the left lower lobe pulmonary artery. The decreased concentration of contrast is not as striking as that seen with pulmonary embolus, and is homogeneous throughout the cross-section of the artery, usually seen on only one, or at most two, contiguous slices, as seen here. This is thought to be due to poor mixing of blood and contrast in the right ventricle. This is more often seen the faster the scanner. With the electron beam CT, I've seen a completely unopacified main pulmonary artery surrounded by pre- and post-slices with fully opacified blood. Contributing to this phenomenon is the patient valsalvaing rather than just holding their breath. The Valsalva maneuver will decrease venous return through the SVC, which is contrasted blood, and increase the flow through the IVC, which is non-contrasted blood. An unusual false positive is a plication defect due to the surgeon inverting the stump at the time of lobectomy. CT angiography has emerged as a test with high sensitivity and specificity for the diagnosis of pulmonary embolus. For many, it is the initial and only test used for this diagnosis.